It's great to be here. Thanks, Jerry. I'm just going to talk you through a little bit of ocular hereditary disease and what it means to studying genetic disease and treating genetic disease, because the whole point of doing genetics is to be able to understand disease better and treat our patients instead of just giving them a drop to go away with. That'll make them better, as we might do in a glaucoma clinic. We want to get to the heart of the story, just as our glaucoma colleagues want to as well in the genetic world. So I'd like to take you for a walk into our retinal clinic, and quite often our patients come with their dogs, they come with walking sticks, and they're not able to see very clearly. And they are not able to see might include many components. They may not be able to see in the center very clearly, or the periphery of their vision may be affected. They may not understand contrast very well. They don't see kinetics in the periphery of their field. And this may be progressive. It may be a decrease of vision with loss of contrast and night blindness and increasing field loss, which makes some of our patients even give up driving a vehicle. So what do we see in a genetic clinic when we look into the eye? Besides looking into the eye, we also watch how our patients enter the room, what their levels of vision are, who they are, how they're related to each other, who their forebears were. And all this is because we're interested in that little bit of DNA that you've been talking about all this while. So there's I know by this time you've understood enough genetics, so I'm not going to explain a little bit about the double helix or where bases live or what they're composed of. But our whole point is to being able to understand disease better. And ocular disease has a genetic component all the time, and hereditary systemic disease has an ocular component. So you see, it's quite important to know our ocular genetics. And 1/3 of all hereditary disease has an ocular component. So if you have a patient in a medical genetics department, they often send the patient over to have their eyes examined just to see if we can pick up any clues and give them a good idea about the diagnosis. And quite often it behooves the ophthalmologist to come up with the right diagnosis if we can so help these patients. As you might notice, as in Marfan syndrome, for example, it has a cardiac component and an eye component, and picking up the eye component can almost save the patient's life because his cardiac disease can kill him. So the commoner disease that I have studied for quite a long time in my life is Leber congenital amaurosis. Here you can think of it as the worst form of RP, where the patients are born with very poor vision and an inability to focus. And a mother is very sad when she notices that the child that she's given birth to doesn't focus on her face. It's a moment that every parent dreams of, being able to look at the child and smile. And when this doesn't happen, it causes a lot of concern. As the child develops, you notice that they may even complain of night blindness. These children also poke their eyes, which is a form of visual stimulation first noted by Franceschetti. And you see that in this picture. One of the patients that I had seen earlier on came from a community of the Amish, which are a very religious community that live in Pennsylvania and some other parts of the United States and Canada. And this child was brought to us with nystagmus and a very sluggish pupillary reflex with diffuse retinal mottling. And the retinal vasculature was slightly attenuated, and a faint pallor of the disc was noted. And the mother was quite certain that nobody in the family had this disease, although she did give us history of a lot of consanguinity because they married their cousins. Sometimes Leber's is also associated with other conditions like keratoconus, cataracts, strabismus, and even anophthalmus, because these patients keep pushing on their eyes. So the child that came to us, although it's many years later, was also described in the early days by Leber, who was quite prolific in his discussions about various ophthalmic conditions. And interestingly, he pointed out that it was both clinically and genetically heterogeneous, which means it was caused by a number of genes, and the phenotypic picture was quite variable. These patients also present with a remarkably extinguished ERG, and quite often you're forced to repeat the ERG in patients, especially if they were done in centers that didn't have a very good system, because it's a horrible thing to go out and give the wrong diagnosis to a family when blindness is involved. So with genes and loci, you notice that currently this particular disease has 16 16 genes discovered and a few loci that are being worked on. It's also heterogeneous, and you can have an autosomal dominant variety rarely, although it's largely recessive. And you can also have systemic associations with this disease. When you see patients in the eye clinic and they have systemic associations, it's important to get the pediatric neurologists or the pediatricians involved, because they're going to help the patient entirely, while as we help only their eyes. And here's a little collage showing you the different phenotypes that you can get when different genes are involved in LCA. CEP290 is one of the genes that was first noted in a worm, and it is the commonest LCA gene that we can see to date, and accounts for a larger percentage of our patients affected with this disease. Interestingly, it's also been associated with Joubert syndrome, where you see, cerebellar aplasia, and quite often you would have noticed from your time in medical school, or occasionally when you've seen patients with the MRI finding of a classical molar tooth appearance. Now, this patient that I told you about earlier, who presented from the Amish group, she had a mutation in the libacillin gene. It's part of a ciliopathy, where the cilia and the photoreceptors in her eye are not functioning clearly, so there's poor intracellular protein trafficking going on, and the cells don't talk to each other well enough. But it's enough to cause retinal degeneration. And here's a patient who has been studied by one of my colleagues with the same thing, that is LCA5, which is libacillin, on chromosome 6. The progress of LCA can be quite dramatic. Some of our patients have very atrophic looking retinas, as you see here. This is a family from northern Pakistan, studied by a colleague. Very different from the picture that I noticed in the child that I saw earlier. It can be progressive in some patient. Here is an Indian patient with a macula that doesn't look great, and mottling of the retina, also having a libacillin mutation. So it's possible even within the same gene to have pictures of the phenotype looking remarkably different. What happens when a child comes to our clinic? Of course, we as ophthalmologists look into their eyes, so we are able to identify the phenotype. The genotype is what is going to let this family decide whether they're going to have more children, and what their chances are when they have children who are blind, and how they're going to cope with the situation. And it's also important to study the natural history, because often parents ask us, what shall I do with this child? She's a little blind, or you think she doesn't see. Do you think I should put her in the blind school? Or should I teach her Braille? And you are faced with making this decision for them, because they feel you know the answers. Although currently all blind children are being taught in mainstream schools, some patients still benefit greatly by knowing Braille. So it's important to understand the family and counsel them, and also prepare them for therapy, because we now know that LCA, what we've been studying for quite a long time, from the time Labour described it in 1869 to almost 2012, we've come a very long way, because this disease was described long ago for children who are blind, and all these years we've looked at patients in the clinic. We now catalogue their phenotypes and genotypes, but in the old days we all looked down sadly, waved our hands and said, I'm so sorry, your child doesn't see, and that was it. So today I want you to feel encouraged that there is treatment for genetic disease. These patients who came to us with sticks and dogs have some treatment in the horizon for them, because mice can see, dogs can see, so why not humans? And along came gene therapy, a geneticist's dream of proving that it was possible to put in the gene that wasn't functioning and getting the patient to see. This particular disease, this particular version of LCA that is treatable currently with gene therapy, is one associated with RPE65, which lives in the retinal pigment cells and is part of the retinoid metabolism, so that we can regenerate vitamin A to be able to see again. So it's remarkable in the sense that you just inject this gene, using an adenoviral vector, which was alluded to earlier, into the retina, subretinally, quite as you would do for any patient having retinal surgery, and then hope that the gene populates the retinal pigment epithelial cells and the patient's able to see. So here's a picture here. I'm afraid my video doesn't work excellently, but it just shows that there's, you can raise a little bleb and you put it in the parafoveal area. It works better when it's injected outside the fovea. And these patients that you see in the pictures below are the early patients who were treated. The treatment centers there was one in Moorfields and a couple in the United States, all featuring fairly small studies. But interestingly, all of them featured children towards the later age, because you want to know how children react to having this treatment done, whether their nerve cells, their photoreceptors and their neurons are functioning reasonably well, and their brains can pick up the fact that they can see. So it's possible for these children to now negotiate a maze after having had treatment. And one particular group that Moorfields treated came from the Netherlands, where these patients live on a little island where there's a high incidence of RP65 associated LCA, and a lot of them are fishermen. And following treatment, they were able to see. This disease causes night blindness, and for a fisherman that's a little bit difficult because he fishes at night. So it was quite interesting to have children from this particular family treated who could see a little bit better. So in current times, when patients come to us, it's easy enough to get a cheek swab. But for families who are contemplating further children and who have this diagnosis of LCA in their families, it's possible to offer them chorionic villi or amniotic fluid analysis, so that it is possible now to look at pre-implantation diagnosis. But let's always remember that blindness is compatible with life, but knowledge is very powerful for every patient. So even if a mother is pregnant, it's important for her to know if the child she's carrying, and if she wants to know if the child she's carrying is going to be blind, it's important to help her with this process. Interestingly, ophthalmology has been quite ahead in the world of DNA. The disease gene mapping for X-linked RP was first done by, in the ophthalmic world by Show Me from London. And as we look at disease and understand inheritance, it's important to look at the various types of inheritance which was brought to you earlier, and to counsel patients regarding their risk factors or their amount of risk at having a sibling if a sibling is affected, what their risks are, if a relative who's distant, what their risks are. But remember, this is still a statistical index, and most families go ahead armed with this knowledge to have their own discussions and their own religious beliefs and their own cultural beliefs on how to cope with disease. Interestingly, ophthalmology, as in everything else, is related to development, and here it's important to just look at development from the previous time of remembering that the eye develops from, the forebrain in the form of an optic vesicle, and it gets proceeds. It's also important when we understand syndromic disease to remember that the eyes develop around the same time as other organs. So that's why it's important to look at other organs when we have children present to the hereditary eye disease clinic. Even postnatally, you notice that patients, have when the digital tufts develop, for example, you notice that the eyes are still developing. So it's important to remember at what week what happens, because that's when genes get turned on and off. And cells too run through the cycle. As you notice here, the ganglion cells which start earlier on have sort of reached quite an end bit along the postnatal end. But you notice that rods keep developing even until 11 days postnatally. So what goes wrong when the gene sequence is altered? Perhaps we make nasty proteins. Nasty proteins don't help us see very well. And if they don't see very well, we lose the function of vision for various reasons. So it's important to just understand inductive signaling and understand how the various layers of the eyes develop and don't develop along this time. If you look at autosomal dominant disease, for example, RP has a dominant version which you may be familiar with, where patients come with decreased vision. And if you look into their fundi, you notice that they have bone spicule pigmentation, and this can happen quite late in life. And one of my old surgery profs had a very mild version of autosomal dominant RP, who I examined later after I became an ophthalmologist, and it was marvelous that he'd had a reasonably full life working as a surgeon, although he often said that he finds vision a bit difficult in the theatre. And as we understand disease, we've got to remember that some of these diseases have cures, and X-linked RP is now being treated in dogs. It's also a celiopathy, and hopefully if dogs can see, I think we can kind of extrapolate that, hoping that there'll be treatment for humans as well. This is a study that Jerry showed you earlier about, the follow-up for 3 years of patients who have been treated for LCA. And it's a very interesting study because it was a dose escalation study, and we ended up coming back with the results that there was very, very little immune response to the recombinant AAV vectors that we used. And patients, actually, their pupillary reflexes got better, their visual fields got better, their contrast and their dark adaptometry even got better. And I think that made it heartening because there are very stringent guidelines for treating children. So there were no systemic side effects noted, so it was a very effective method of treatment. So moving on to the next disease to understand what happens in Tay-Sachs, is that you see a child here who was brought quite early in life, a 7-month-old Jewish child, who wasn't focusing on the mom's face. This is also a very disheartening disease to deal with because as the child is born normally, you notice that they regress in their neurological milestones. So a child who is beginning to show quite good motor development will suddenly start getting hypertonic. And this is quite a sad state of affairs, and it's a very hard diagnosis to give to patients. But the good part is it's an autosomal recessive disease which has been studied very extensively in the Ashkenazi population because they have a very high gene frequency. So it's even possible to see for families who come from this particular part of the world to have themselves screened even prior to them getting married, because then they have a good idea as to who's carrying the gene. So the patients present from an ophthalmic standpoint with a cherry red spot, and it's because of ganglioside deposition in the cells around, and they present with a very poor pupillary reflex. And each time you see them, you notice that their vision is decreasing and they don't focus very well. So this disease was described by both the neurologist as well as an ophthalmologist due to deficiency in an enzyme, and it is fairly frequent in certain cohorts of population, more of whom have been, who in the past at least were marrying quite a lot of their relatives. And it being a recessive disease, it was propagated quite a lot. Interestingly, it also has a very easy enzyme assay test that you can do to check the activity of this disease, and it was the first successful medical mass screening test used in medical genetics. So being called on a pediatric consult in a neuro unit can sometimes be, seeing a hypertonic child. Perhaps you should keep this in your mind if you see a child whose retinas don't look quite right. So here are the lysosomes bursting with the accumulated material and an EM showing the same. So there are different types of Tay-Sachs, and the one that we commonly see is the infantile one, but there is one even in the adult. And what we're interested now is to understand how to treat these patients. So it is possible to have enzyme replacement therapy and to manipulate the gene therapy as well in these patients, and currently we even have a component called OGT which is being tested. So counseling basically helps people, and it helps them understand their disease, and it helps them plan their lives basically, because people are touched by a lot of guilt when they're told that their child has a genetic condition. But all of us sitting in this room have some genetic condition too, except that ours may be more complex and they may not be monogenic diseases. So it's important to counsel our patients and walk them through the situation. The commoner things that we sort of see in our daily ophthalmology practice is refractive errors. And quite often we are at surgery and we see patients who have small eyes that we haven't taken note of in the on the surgical table, and we wonder if we should have done more. Now that's becoming a lot less because it's possible to have their scans done and look at everything prior to meeting them in theatre. Some of these patients might have nanophthalmus if they have very small eyes, and here's one of our patients at 25 years who had a hyperopia of 14 diopters and came with angle closure glaucoma and choroidal effusions. It's now been possible to identify the gene that causes this. And anophthalmos has other genes too that cause this condition. So I just want to leave you with the idea that it's possible to treat genetic disease, and there is light at the end of the tunnel, and our patients will actually be able to see because gene therapy has made it possible for them. Just like now we're now using stem cells of the embryonic and the adult stem cell variety. This is a 9-week-old embryo, and it's possible now to treat both Stargardt's and AMD as well. So vision at last for our patients. Thank you.